Let's turn to video 6, Guidelines for the Management of Pediatric OCD. Now, I will say that insight-oriented therapies don't seem to help the core obsessive and compulsive symptoms. To date, the effective treatments include individual or individual family-based cognitive behavior therapy, which includes exposure and response prevention therapy, and the potent serotonin reuptake inhibitors. There seems to be general consensus in the field that mild obsessive-compulsive symptoms, which are characterized by a children's Yale-Brown obsessive-compulsive scale score of 16 to 19, the recommended treatment here is CBT alone, and the data to date suggests that CBT has a higher effect size than the selective serotonin reuptake inhibitor. For moderate OCD symptoms with a SIBOC score of 20 to 29, we recommend starting with either CBT alone or CBT plus SSRI. Now, obviously, there are some families who will not consider medicine under any circumstance. There are some who want to try cognitive behavioral therapy first before they go to medicine, and some who think the symptoms are significantly disabling that they're willing to try both cognitive behavior therapy and selective serotonin reuptake inhibitor treatment initially. I would also emphasize that there's good data to show that if you use cognitive behavioral therapy with medication, you can end up using lower doses of medication oftentimes, and that may result in fewer side effects. For severe OCD symptoms, that's a SIBOC score of 30 to 40, we recommend starting with CBT plus SSRI. Typically, those symptoms are so severe that cognitive behavior therapy alone is not sufficient to take down the anxiety to levels where it can work. And so you need a medication intervention to at least bring the anxiety to a level where the cognitive behavior therapy strategies can work. Now, in some of the trials, the data is pretty good that combination therapy, that is cognitive behavior therapy plus a selective serotonin reuptake inhibitor, was superior to treatment with medication alone, to treatment with cognitive behavior therapy alone, and superior to placebo. So there was a bigger and better response, and that there was an increased likelihood for remission with using both cognitive behavior therapy and selective serotonin reuptake inhibitor. Remission is characterized by a SIBOC score less than 10. That's not often obtained in obsessive-compulsive disorder treatment, particularly in children and adolescents. Often there is a response, but there can be continued functional impairment. Partial response, here we're talking a 35 to 50% decrease in SIBOC score after a minimum of 10 weeks of an optimal tolerated dose. For non-response, that's a less than 35% symptom remission. In terms of remission, what we recommend here is a maintenance cognitive behavior therapy. Our program will give booster sessions for at least 12 months as needed. Maintenance of SSRI at an optimal dose for 12 months minimum. So what we recommend in our clinic is, in terms of medication, once there is a medication with sufficient improvement at that dose, that's when the clock starts for 1 year. Partial response, in this case, you can switch to another SSRI. That's a perfectly reasonable recommendation. That being said, some people are somewhat hesitant to do this because they feel like, well, if I switch to another SSRI, will I lose the 35 to 50% symptom reduction? And so one thing that can be done, if it hasn't been done previously, is augment with cognitive behavior therapy. And another is to augment with the serotonin reuptake inhibitor, which is also a norepinephrine reuptake inhibitor, clomipramine. Augmentation with clomipramine can significantly increase treatment response. And there are studies that have shown this. For non-response, your options are to switch to another SSRI, augment with cognitive behavioral therapy if not previously administered, augment with clomipramine, or augmenting with an atypical antipsychotic such as risperidone, quetiapine, aripiprazole, and treating the comorbid disorders concurrently. Medication dosing guidelines for pediatric OCD. The mantra, as any child and adolescent psychiatrist and most pediatricians know, is start low, go slow. I've seen more medication approaches, more medicines that are perfectly reasonable, ruined by increasing the dose too rapidly. But all you're typically doing when you do that is increasing the risk for side effects and taking away from the child's ability to become tolerant and adjust to the medicine. So I like to let medication work for at least 2 to 3 weeks before adjusting the dose upward, because we know that even at the lower doses, the longer they're in the system, at least for many patients, you can see more effectiveness. So for sertraline, starting dose in a child is 12.5 to 25 milligrams per day. In an adolescent, 25 to 50 milligrams per day. I typically like to start at 25 milligrams, again, starting low. And the typical dose range is anywhere from 50 to 200 milligrams per day. For fluvoxamine, the starting dose in a child is 12.5 to 25 milligrams per day, and in an adolescent, it's 25 to 50 milligrams. Now, I'm more conservative, so I like to start out at 25 milligrams in an adolescent and titrate the medicine gradually. Why do I do that? Because I have a number of patients where that's enough, where I have not had to go up higher. On the other hand, the dose range for fluvoxamine is 50 to 300 milligrams, and I wouldn't stop increasing the dose gradually until I got to the upper limits, because there may be an effective treatment response. For fluoxetine, the starting dose in a child is 2.5 milligrams to 10 milligrams per day. In an adolescent, that starting dose is 10 to 20 milligrams. And again, I never start higher than 10 milligrams per day. I like to give children, adolescents, as long as possible to get used to the medicine. I find that if they're more tolerant to the medicine, if we go slower, that just as much is accomplished in terms of effectiveness, but far fewer side effects are observed. In terms of paroxetine, the starting dose is 2.5 milligrams to 10 milligrams in a child, 10 milligrams in an adolescent, and the dose range is anywhere from 10 to 60 milligrams. For citalopram, the starting dose in a child is 2.5 milligrams to 10 milligrams per day. In an adolescent, the starting dose is 10 to 20 milligrams per day, and the dose range is 10 to 60 milligrams per day. For escitalopram, the starting dose is 2.5 milligrams to 10 milligrams per day, and for an adolescent, the starting dose is 10 milligrams per day. Escitalopram has a dose range that's very limited, between 10 and 20 milligrams, and it and citalopram are a nice choice of medicine if the child is on a lot of other medications, because escitalopram and citalopram have the fewest drug-drug interactions. And finally, clomipramine, which remember is a non-selective serotonin reuptake inhibitor. So it impacts both serotonin and norepinephrine. The starting dose is 6.25 to 25 milligrams in a child and 25 milligrams in an adolescent, with a range anywhere from 25 to 200 milligrams per day. One other key point is that obsessive-compulsive disorder in children and adolescents is actually, next to ADHD, the area where there are more FDA-approved medicines. So there are 4 FDA-approved medicines for pediatric OCD, and they include sertraline, fluoxetine, fluvoxamine, and the non-selective serotonin reuptake inhibitor, clomipramine. Now, I bring that up because there are other medications, other selective serotonin reuptake inhibitors that work perfectly well in pediatric obsessive-compulsive disorder, but are not FDA approved. While they work, I like to go with the FDA-approved medicines first. One, they have far more study. Two, from a medical legal standpoint, you're using an FDA-approved medication. And three, the companies have not done all of the due diligence in terms of getting the FDA approval. The decision regarding which SSRI to use should be made in coordination with the family based on family history of positive response, potential drug-drug interactions with other medications, and the side effect profile. Let's say there's a child whose mother has a panic disorder and responded amazingly well to paroxetine and had a horrible side effect or non-response to fluoxetine, which is FDA approved. In that particular situation, I may want to go with the medicine where a first-degree relative had a good response. If a child is on a lot of other medicines, then I might be inclined to consider a medicine with fewer drug-drug interactions, such as escitalopram or citalopram. At present, there are no head-to-head studies that have been conducted to evaluate the efficacy of different SSRIs for treating pediatric OCD. That being said, systematic review and meta-analyses have found slightly larger and less heterogeneous effect sizes in OCD patients treated with fluoxetine and sertraline compared to fluvoxamine, suggesting potential superiority of these treatments over fluvoxamine. All three SSRIs, though, have very good tolerability and are clearly superior to placebo. Treatment guidelines for pediatric OCD recommend cognitive behavior therapy as the initial treatment of choice for children with mild to moderate OCD, and CBT alone or used in combination with SRIs for children with moderate OCD, and CBT plus SSRI for children with severe cases of OCD. There are 4 FDA-approved medicines for pediatric OCD, and they include sertraline, fluoxetine, fluvoxamine, and the non-selective serotonin reuptake inhibitor clomipramine. For those who are partial or non-responders to treatment, additional recommendations include a progression of additional treatment steps such as switching to another SSRI and or augmenting with CBT if not previously administering, augmenting with clomipramine, and then augmenting with an atypical antipsychotic.